All right, with Dr. Ammar right now. Hello, yeah, can you please introduce yourselves and give us a brief about the case?
Sure. So my name is Majid Alsahafi. We are here with Dr. Ammar. We have this 47-year-old woman who has a history of diabetes and hypertension. She underwent a screening colonoscopy, and she was found to have a large bulky lesion in the right colon. At that time, biopsy was taken and showed low-grade tuberculous adenoma.
ماجد لو تقرب بس الميكروفون للفم شوي.
Okay, is it better now?
Yeah, better.
Okay, so Dr. Ammar now will take us through optical assessment, and then we'll discuss what's the right strategy for resecting this lesion.
Thank you. So as Majid said, can you hear me good now?
Yeah, Dr. Ammar, very good.
Yeah. Okay, good. So this is a quite an extensive lesion. It's initially was thought to be in the cecum, but actually it's in the from the proximal ascending up to the distal ascending, almost involving the hepatic flexure. So now I'm in retroflexion. The cecum is clear. We've been to the TI. This is the ileocecal valve on retroflexion. So there is no involvement of the lesion into the IC valve, and this is very important in the planning of the resection. Now, as you can see here on retroflexion, this lesion extends here from the proximal ascending colon. It's a Paris 1S granular lesion. So, as you can see, there is a bulky lesion with wide base, and it's globular. The lesion goes all the way to the distal ascending. And just to quickly, we've already spent time examining the area because there was areas of depression on the initial photos. But with close interrogation under MBI, there is no areas of JNET type 3 or NICE type 3, so there is no features of submucosal invasion or disruption of the surface or the vascular pattern. I'll just go on the water here to show you the magnification here of the region. So this is predominantly benign.
Dr. Ammar, can you tell us what is the size of how do you assess the size of the polyp?
Yeah.
And from where it starts, and what is the classification here with MBI?
Yeah, so the classification here is, as we said, is a Paris 1S granular. And I think this lesion will probably be around at least 50 plus up to 60 millimeter in length. And obviously when we inject, it's going to be even much bigger, almost about 30% bigger. Circumference-wise, I think it's also relevant and important. So it's almost at least a third, in some areas almost half circumferential, I think, almost a third. I will say a third circumferential. So that's all relevant when you assess a lesion. Let's have the injection. So yes, it's a Paris 1S granular lesion, almost about probably 60 millimeter plus. So we're gonna, so the two important things here that this lesion is not involving the ileocecal valve as we assessed it, me and Majid, and there is no concerning features for deep invasion or superficial invasion. So I think this lesion for us, we agreed, Majid, I think we're gonna go for piecemeal EMR. We believe that this will be more efficient, it's cost effective, it's safer, and it's based on evidence. I think this will be the right thing to do, at least in our practice, both me and Majid.
Yeah, if you think about the prevalence of cancer in large non-pedunculated polyps in the right colon, it's around 4%. And the risk of covert cancer with this lesion is around 2.8%. And if all lesions like this resected like M-block with ESD, you're essentially going to save only one patient from requiring surgery out of 142 patients having ESD done. So the downside of doing EMR here is very low.
And question for Dr. Ammar, is there a reason, for example, you would say I would try underwater EMR as opposed to?
Yeah, so I don't think there's enough evidence to support underwater EMR compared to conventional EMR in this case. There is no, I don't think underwater EMR will be able to achieve on-block resection in this lesion. So, and I think, we have enough data with the conventional EMR to proceed. Yeah, needle out. Spray there for me. Sorry. And start the injection. Inject quickly. Yeah, keep injecting. Inject. Injecting a quick injection. Yeah, keep injecting. Keep injecting. Keep injecting. Keep injecting. Stop. Yeah. So we're using I'm using an adult colonoscope, 1500, easy, and needle out. And we're using now saline with methylene blue and diluted epinephrine. Inject. Quick injection. Quick injection. Quick injection. with, sorry, yeah, hold on, yeah. Keep it out, keep the needle out. Yeah, yeah, keep the needle out.
So
with diluted epinephrine, 1 in 100,000. So methylene blue saline with epinephrine, 1 in 100,000. Hold on, yeah. Inject now.
So Ammar, when you do this procedure and you do lifting, and the lifting is very easy, when you inject, this makes you more with EMR rather than ESD?
Needle back. The lifting feature, I don't think there's enough evidence to suggest that it should be used as a determinant of which technique to use. Needle out. If it's a cancer, it's a cancer. And I think in this situation, a right hemi would be a good inject, quick injection, keep injecting, yeah. Keep injecting. Stop.
There is no limit for the injection. And you continue injecting until it is lifted, right?
Yes. And it should lift because it's a granular lesion. There's no features of disruption of the surface or the vascular pattern. So from that point, we're not anticipating, I think, any, and it's a granular lesion, so there's no anticipation quick injection, yeah. We're not anticipating any non-lifting feature.
It's important when you inject also
keep
to use the dynamic maneuver,
yeah,
trying to get the lesion into you.
So it looks like it's lifting nicely. The submucosa is loving you today, Dr. Ammar.
Yes, it is, yeah.
Needle out, yeah, and inject now. Quick injection. Nice, yeah. Quick injection, good. Okay. Inject, stop. Okay.
When you inject, is it better to inject from the proximal or distal? Or it doesn't make difference?
It doesn't make a difference. I think it's up to you, but in this situation here, the rationale, needle out. Inject now, yeah. The lesion here is, the scope is much more stable on retroflexion. And I think I want to start on the retroflexion side just to clear the edges, and then we'll probably work our way, me and Majid exchange, keep injecting, yeah. We will then work our way from the forward and try and join them together, but there's no rule for it. But I feel that this part is the most difficult part. So we usually like to start from the most difficult part if we can, and then hopefully the procedure will become easier as we go. But sometimes, as in comparison, just keep injecting, yeah, inject. It's sometimes very hard to go to the proximal aspect, and sometimes you need to debulk the lesion. Give me the snare now, the 20 mil. Debulk the lesion, and then improve your axis, and then you just work out what's best for you.
So what size of snare are you thinking in terms to start off?
So I'm going to use a 20 mil snare, braided snare. It's 20 mil SD 230U from Olympus. So this is the snare I'm going to use today. Yeah, thank you. Okay. So quickly, let's just connect. So we're going to use EndoCut Q. Can you actually change it to 3? EndoCut Q, yeah, 3. 316, no. Yeah. That's it, yeah. So we're using EndoCut Q current, 316, so effect 3, duration 6, and interval 1.
And you can see Dr. Ammar is also using a distal attachment cap from Olympus, and that's improving the axis and visualization as well.
Yeah. Especially, I think if this lesion was thought to be, because when we looked at the images initially, we thought it may have been involving the IC valve. I think this is definitely a situation where you want to have a cap to help you with, pushing away the lips and seeing the proximal aspect of the lesion and being able to maintain your view while you're doing that. Okay. So open completely here for me. Open completely, yeah. Open. Completely open, yeah. Keep it open for the sit, yeah. just checking here. So unfortunately, the lift has deflated a bit, but we'll inject again. So just keep it open there. It's not going in the direction that I wanted. So here I'm deflating, trying to include a margin of normal tissue when I start. Okay, slowly close for me there, Faisal. Close, 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 close. Keep closing, keep closing, keep closing, keep closing, keep closing, keep closing. Stop there. Yeah, okay. Stop there. Yeah. Okay. So now I'm going blind because there's a piece there, but I'm checking mobility, and relative to the rest of the wall, it seems to be free. So we'll go.
So after each cut, we have to examine the base of resection to ensure there's no bleeding and there's no deep mural injury. That has to be treated before continuing the resection.
So the endoscopy picture is just buffering a bit. I'm not sure if someone from audiovisual there can fix it.
We're having the same issue here, I think, even for us.
Hello, do you hear us?
Yes, Dr. Ammar, we can hear you.
Yes.
How's the progress?
We are back here. We are doing an EMR in the right colon. And Dr. Ammar has already removed some of the polyps, and we are continuing with the B-smear resection. And we are using the blue eye for submucosal lifting, which is a prepared lifting solution that comes in 5 cc syringes. And we are working in the retrofix view. And as you can see here, we are injecting lots of submucosal solution in order to have a safe resection. Typically, in the right colon, we use a 15 millimeter snare, but for this bulky lesion, Dr. Ammar here is using a 20 millimeter snare to do some debulking, and then we'll later on switch into a 15 millimeter snare to reduce the risk of deep mural injury.
So let's have the snare.
So you can see that the axis is a little bit difficult here. We had some looping of the chronoscope, and we're working in the retrofix view because the lesion wasn't very easily visible for resection in the forward view. It's important that you test your chronoscope before starting the case to ensure that it has a good retroflexion ability to have this nice view in the retrofix manner.
Yes. So any questions from the audience?
Hi, Ammar.
Yeah, we have one question here.
Ammar, you can hear me, Ammar? Hello?
Can you hear Dr. Ammar the question?
No, we don't hear
We
the
don't
question.
hear a question. No, open.
Hello, Ammar. Do you hear me now?
If you can say the question, I can repeat
the
it to him.
question, the bowel seemingly behaving very well. I wonder he's giving Buscopan or glucagon.
So we only hear the moderator. We don't hear.
So the question, Dr. Ammar, is do you use any Buscopan or glucagon to help you in their section?
Very rarely. In the colon, often if you retroflex, it stabilizes your position. So in the duodenum, it's different. I do that. In the colon, you can use it, but I've not, to be honest, needed to use it very rarely, extremely rare, extremely rare. So you can use a 10 milligram of Buscopan, and then you can add another 10 after that. Usually, you don't want to use too much because it can induce tachycardia, especially if you're using epinephrine in your solution. But you can use also glucagon, so either or. So what I'm trying to do here is to safely get the snare in the right area without having a muscle entrapment. So I want the specimen or the tissue to capture naturally without forcing it, because then you could theoretically get a muscle in the snare. And then obviously you get a perforation.
So, Dr. Ammar, if the patient is stable and young and he no comorbid, actually, isn't it better for, I'm just saying from the size, to go for surgical resection rather than EMR or ESD if he is healthy otherwise? So we
Open again.
reduce the chance of recurrence?
So recurrence in the era of thermal ablation of the margin is not there. It's
The problem is you don't know about the lymph node. When you do resection, you took in block all lymph nodes.
yeah, but this is a benign lesion, doctor. It's not a cancer. So there's absolutely no risk for submucosal invasion, and there is no risk for, if it becomes a cancer, that's a different matter. Close. Say again?
Okay, thank you.
Okay, thank you.